Okay, Dr. Gwon.
Hi, welcome back again. Hi.
Okay, please introduce
So,
your cases and your colleague.
Yeah, sure. My name is Hyeo-Cheol again, and this is today's operator, Dr. Hyeo-Cheol. He is also got a license of a proctor of Edward Sapiens recently, and Taeku Park, working with us. Actually, firstly, I'd like to show briefly the coronary angiography of last case. Slide, please. I think you are in the coronary theater. You are more interested in the coronary. Next. Yeah, this is final result of first the calcified trifurcation lesion.
Beautiful,
So,
beautiful result.
Next. Next. Next.
What did you do at the end? Did you do
Yeah.
a culotte or a T-stenting or what?
Okay, actually, mini crush, meniscus technique. Actually, afterwards, the camera is off. I found some dissection inside of LAD2. So it was too risky to remove the wire. For culotte, I need to remove the wire. So
Yeah, that's what you said.
Yeah. Actually, I'm not sure, but I'm wondering that the OCT may have some contribution to the dissection. So anyway, we did the final kissing balloon with the NC balloon and part, and the result, I was satisfied with the result. Okay,
Anyway,
going back
that
to
is
comment.
the perfect result and the educational
very much.
cases. Please
Yeah,
keep
thank you.
going on the TAVI cases.
Okay, so Dr. Park,
Yeah.
today's case.
Yeah. Next page. She's an 81-year-old female. She admitted for dyspnea, exogenous dyspnea and chest pain before 5 months ago. His SD score is 3.4 and Logis Euro score 8.4. And the case is a normal sinus rhythm. And echo showed a tricycle aortic valve with a 41 millimeter mean gradient. And aortic valve area is 0.6 with minimal area. And LV function is preserved. Next page, please. CT annular area by CT is 401 10 16, and area driven diameter is 23. Next page. And this calcification is located on tip of the NCC cusp. Next. The coron height is 12, right and left main ostium. Next. So periparately is so good. And next. So it's aortography and visual calcium is NC steep. Next. So RCA is originating from the left cusp, and left angiography showed left circumflex severe stenosis with a decreased TIMI flow, and mid LAD showed moderate intermediate lesion. Next.
So she was presented as acute Crohn syndrome at the time?
Yes, on 17.
Presented as ACS.
So LAD showed intermediate lesion, then mid LAD. Next. So we 1 month ago, we performed the PCI and circumambulatory implanted 40 millimeter Oshiro stent. Next. So we select the valve, Sapiens valve, and valve area is 416. So it's a borderline in between 23 and 26 millimeter valve.
The left side is area. The fourth area. The 26
next,
oversized.
Yes, but Edward recommend measured 431. So also borderline area 23 and 26 millimeter valve. But Edward measured shear phase 25% phase, so slightly larger than our measurement. Okay, next. So sinus diameter is 29, and SD diameter 26, and SD height 18, slightly lower. Okay, next. So our issue is a severe aortic stenosis patient with coronary artery disease, and we plan Sapiens valve is discussed between 23 and 26 millimeter valve size. And how about treat critical coronary lesion? PCI will differ. Yeah.
Any other comment for the this treatment strategy for this patient?
Yeah, Dr. Gwon, this is Ramesh Dagubati. I think this is a really good. I would have done an FFR-guided PCI of the LAD at the same time as a circumflex because LAD also has a slow flow, or even without FFR you could do it. And I think my valve would be 26 minus probably 2 ml, and I think that's pretty much it.
So, yeah, Dr. Che, what do you think? What's the plan?
Yes, I agree with your opinion. Just the 26 millimeter minus 2 cc is optimal for the
사이즈
사이즈
차트 좀
please.
달라고.
this patient
size
because we usually use the 10% oversizing.
How
It's,
about the size of the sinus of Asava?
It's more than 30.
29.
29.
Okay.
Yeah.
Dr. Gwon, says from your excellent case, for the PCI, would you consider to do the PCI before the TAVI implantation? Because usually we will use a certain amount of contrast when we do the TAVI.
Okay.
So do you think in this case, should we do the PCI before we do the TAVI, or would you defer the? Because I don't know when we do the TAVI will be influence of the coronary or not. So maybe we should do the coronary first before do the TAVI. Thank you.
Actually, yeah, thank you for a comment. Actually, one of the issue is the role of FFR in coronary intermediate lesion in the patient are prepared for TAVI procedure. This is old age. And the FFR, the cutoff value 0.8 is not good indicator for ischemia. And the old age patient with poor exercise capacity. Secondly, last slide, please. There is an interesting paper published by Dr. Justin Davis that the FFR was changed after TAVI because the LV thickening or reduce the flow due to arc stenosis, due to the afterload for the LV. The flow was slowed. So afterwards, flow was released and the flow was increased in coronary, maybe some decline of the FFR by 0.2. So FFR before TAVR is not so accurate after TAVR. So actually, in this case, we measured FFR to prepare for this case. And a month ago, that FFR was 0.71. Criteria was significant, but anyway, this is old age. And today, how about today? Today's FFR. FFR?
I'm
Show the
Dr. Yin
FFR.
from Taiwan. If the FFR is 0.71, why not do
No.
PCI for the
Today.
LAD?
Okay.
I agree with Dr. Yin's opinion because
Sooner or later, the patient may get atherosclerosis and progression of disease.
Today's FFR was 0.77. How about that?
I still will do it because it's a proximal LAD lesion,
Okay.
supplying a big territory.
So,
the other opinion about the panelist.
Several months ago, I performed a similar case. At that time, before TAVI, FFR is 0.82, but after TAVI, is 0.72. So I like to recommend post-TAVA FFR procedure and then PCI. Of
So
course, this
actually,
patient is
this
already.
we are in the coronary theater, so not for a TAVI procedure. TAVI is boring now. So let me check the FFR after the TAVI procedure. It'll be interesting. And also, the sapient valve have a wide cell opening in the upper part of the valve, and they say it is easy to cannulate the left coronary.
No.
So let's see. what will happen.
No problem, Dr. Gwon. Hi, it's Eric again. You go for it and go the TAVI because we're in a TAVI procedure. I think that what was tried to be emphasized here and this is what I feel, is that we're trying at the same time to go to a lower and lower risk patients and younger patients,
Yeah.
and we should not compromise on the full treatment of
Sure.
cardiology, whether it's valve or coronary or whatever.
Yeah.
So we're
Right.
not talking just about this patient, but in general, I think that the common practice is going to be in the very near future that you are doing the whole coronary treatment before you are
Right.
doing the TAVI procedure.
Right, yeah.
But this is just for sake of discussion, and you go for it
Yeah.
and show us your
So
skills.
the point is that, my point is that it's still not clear. FFL 0.8 is a good criteria for the old age people. I don't know. And FFL 0.8, lower than 0.8, the interpretation is that you should dilate it.
밑에
No,
보여주세요, 밑에.
actually, you can dilate it. Above the 0.8, you should not touch
No,
it.
I think you're absolutely
Australia.
right. If you have a doubt, you can always do it in the future.
Yeah.
But if
Yeah.
you do not have a doubt,
future,
we try to emphasize the
So,
point. But
anyway, the point is that I like to share the FFL change after TAVI procedure. So I like to see that. Actually, I have never done that before. So
Okay,
I like to
keep
share
going.
with you.
In some point of view, it makes sense in your comment, but the reason why, but you guarantee the access for the left coronary ostium should be wide open. It's easily do the PCI after the TAVI procedure.
Yeah.
조금만.
Let's
Okay.
see
위에 보여주세요.
how easy is that the PCI after the TAVI procedure.
Okay.
That's the observing. That's the one point for this TAVI procedure.
And because it's sapien, I think it's not going to be a problem. But you have to think about if you are using Evolute Pro, do you think aerial that would be making an
Yeah.
issue?
Yeah.
Accessing the coronary
Well,
artery afterwards?
well, I sound like a broken record whenever I'm being asked that, because people think, and I think justified, that it's easier to go through after TAVI with Edwards. But as we gain more and more experience, we know that going for PCI after self-expandable valve like Evolute, it becomes easier and easier. And in this sense, the guideliner became my best friend in the cath lab. You put it close to the coronaries, then you're just digging with the wire the entrance to the coronary, and then you push the guideliner and you're done. So it's going to be very easy with a self-expandable valve as well. But in this case, I think he's going to go for a good job and will be able to do it in the future.
What size of it, the Sapien 3?
26, 2 cc on the field. So we are aiming a little bit higher because the shortening of the lower part is less than the nominal size.
But
Okay,
do not cross the ostium of the left coronary.
Sure.
Oh, sure, of course. So, but the sinus is large enough, 29. The more than 28 is a criteria. And coronary is a borderline, but still more than 12.
Okay, we are going to.
Okay,
Okay.
okay, yeah.
자, pacemaker ready? Pacemaker on. Okay, inflation 천천히.
2.
Okay,
Okay.
세게. 1,
하나, 2, 3,
Notice you didn't do
4,
it.
5.
Okay.
Okay.
Yeah.
Inflation. pacemaker.
패싱.
페이싱 하세요.
Pacing.
패싱 60.
프레셔 좀 비춰주세요. 프레셔. 저쪽. 카메라.
T 봐주세요.
Yeah, pressure is coming back.
Okay.
We want to see the angiogram, and if it is available, show us the post-harbor pressure wire in the LED. It is really interesting.
어때요? 엔지오?
Asking to me?
자, 테스트. 엔지오 테스트.
Blood pressure is low. No, not yet. Okay.
해줘.
Pressure. No. BP.
Can we see the blood pressure?
Yeah. blood pressure.
Can you
좀
please
비춰줄
show
수
us
있어요?
the hemodynamics?
Blood pressure. Blood pressure is low.
T
So
말고
pace the beat. The pacing beat.
T 이미지 필요 없는데요.
이걸로
T
바꿔주세요.
말고
헤모다이나믹은 조그만 거, 그다음에
헤모다이나믹.
NGO를 갖다가 프로로를 갖다가 큰 화면에 좀 보여주세요.
예, 지금 헤모다이나믹 올라오고 있죠. Blood pressure was low as about 50, but now 81.
We
Still
cannot see it.
pacing bit. The lower,
Okay,
Okay.
okay.
pacing 좀 낮춰봐봐요. Blood pressure is.
페이싱 낮추세요. 60으로.
Pacing is causing
T-
hypertension.
Yeah,
좀
but
complication 있는지
I don't know if you
Patient.
remember, but I emphasized in the last session.
Yes.
You remember I said that
you
I don't know
turned on the
why,
pacing.
but
That's one of-
always after Edwards, you have to be a little bit more patient for the blood pressure to recover.
Yeah.
And you see it again and again, and here again.
So
I
today,
just,
okay.
I just
go on.
didn't understand, Gwon.
Yeah.
I think you're doing a wonderful job, but why don't you give a small injection before inflating the valve? I mean, you did not try to save contrast. You gave injection
Yeah.
before, and you just rely on your memory where the annulus is, or what?
Yeah, that's what we are doing here. That depends on the cath lab. Sometimes the pigtail inside during implantation
No.
or give injection, but we don't do this, and most of cases not a problem here. Anyway, actually I like to show the TE. Today's Eun-Kyung Kim, our echocardiograph specialist. Can you show her? Yes,
Yes,
working
hi,
on it.
good morning.
And besides, we have anesthesiologist, Dr. Min. Say hello. Okay.
Okay. Please.
Okay,
Please
now
explain it.
we can see the mild probable AR from the 7 o'clock to 1 o'clock, but the AR flow, the observed in 7 o'clock might be wire-related AR, so the total amount of AR is thinked as mild now.
Okay. So before the first balloon, we'll check the angiogram.
What you say?
Yeah.
There is some AL.
Yeah.
Show that just please.
Mild.
How many percent? It's, every time it's quite difficult to say that the amount of AL by TE.
I
It's,
would
20
post dilate with
20%?
1 cc.
Yeah, sure, sure. Yeah.
Then you have the balloon
So
still there.
there is a central AL, but maybe we can just test the shot.
Yeah, sure.
Yeah. Test the shot.
NGO.
Yeah,
Yeah.
there is AL, at least moderate.
좀
right?
정확히 좀 이거
Yeah,
이거 스트레이트하게 좀 해줘. 허리.
1cc?
네, 1cc.
1cc?
예.
들어갔어?
저거 좀
Yeah, already ready.
보시겠어요?
Okay.
이거 좀 정확히 가운데로 가게 해주라고. 디바이스가 앵글을 주라고 크레니아를 보주든지.
Okay,
됐어,
okay,
됐어.
okay.
됐어.
Okay.
갑니다.
View 위로. Center. Yeah.
How was the AR on your iotogram? You did an iotogram as well, right?
Yeah, just to test it. Yeah, AL before the procedure there was no AL, almost trivial AL. 저거
네.
카테터 위치
네.
뒤로 좀 더 빼야 돼요. Okay.
오케이. So pacemaker ready.
Okay, 1cc overfill. Now 1cc underfill.
제거한 거죠?
Pacemaker on. balloon.
balloon.
What was that noise?
1, 2,
3,
3,
deflate.
Deflation.
4.
Pass it
Okay.
off.
Off.
Okay.
Same balloon with
Same
1
balloon. Same balloon, 1cc more.
1cc more.
Okay. 해줘.
바람을 네.
Okay.
The blood pressure is now 50. It's a little bit slow coming back. 볼륨도 좀 주시겠어요?
페이스메이커를 70회로 좀 해주세요.
70.
오케이. 어떻게 티 좀
Interesting that the lower part of the valve there was a
하이드레이션 좀
PVL.
해주세요.
This is central AL, I think. Yeah, lower part is the central.
Please show us the
T on the screen, please. T 좀 올려주세요.
I think we can centralize the wire a little bit so that we
Right,
don't mix up
right.
is it at the
Yeah.
side or it's actually the wire
Okay.
leaning against one part of the
I
frame.
totally agree.
I think
Personally, I don't go for post artation
Can we-
because it
annular
seems
level.
that the frame is occupying quite a lot,
Annular
and then
level.
from
I totally
TE,
agree.
the measurement is only 19. But
Annular level.
definitely here is a good job, but
show that
maybe
it's
I'm a little bit
annular
conservative. I may
You're
think though.
absolutely right.
level. That is
No, but
improved a little bit.
there were two jets of AR. One was actually at 7 o'clock, which is, we agree right now, if you see, that is from the central wire. There was
central
an
wire,
AR from 12 o'clock to almost like 10 o'clock,
Yeah,
which has
yeah.
definitely minimized now with the
Right,
extra 1
right,
cc.
you're right,
Understand.
yeah,
So, but I
agree
want
with
more information. For example, even diastolic pressure, I don't see diastolic pressure, so I
Yeah.
would wait a little bit before making
Pressure.
a judgment.
you. Right. So
Dr. Gwon, we are
Pressure.
happy with the
pressure 좀 붙여줘요.
We are very happy, but you know, I never ever take a decision for post dilatation before I take the wire from the ventricle, because the overestimation of AI and even of the paravalvular just
Yeah.
by the wire is
Yeah.
sometimes
Okay.
really robust. So I'm taking the wire out, I'm giving injection, I'm looking at the echo, whatever, and then I decide.
Dr.
Yeah.
Gwon, we will move to the SNU,
Yeah,
and
right,
please,
yeah.
and we
I
will be
think,
back.
and that, at the comment, actually, T is the very good tool to differentiate from the central AL to
Right.
PVL. That's why you monitor the T during the procedure is better, because angiography only is not the good indicator of the PVL when central AR is large. So thank you. So move on.
Okay, thank you. We will be back.
Very, very nice so far. Thank you, Gwon.
Yeah.
이거 맨 오케이.
Dr. Che,
Yes.
okay,
sure.
please
Yeah,
show
okay.
us the final result or the.
Yeah, please. Final.
John.
Yeah, this is a final angio. You can see the no AL.
Okay. So actually, this is the 13% oversize. So the non-calcified lesion, about 12 to 15% oversizing is optimal, I think.
And then
Personally, it's excellent result. Now I'd like to the question about the LAD lesion. Oh, you will try
Also?
that.
Yeah.
Okay, it's perfect.
Test.
Please show it.
Okay,
Okay.
let me cut it back and try again.
Very
wire.
interesting.
Actually, yeah.
Please show us the
Yeah. Test.
FFR value of the LAD.
Yeah. Okay.
Real
FFR.
educational.
Yeah, FFR specialist, Dr. Park. Yeah.
So positive things of this device is easily can the guiding
Yeah.
of the left coronary
JL4
after the TAVI procedure.
JL4.
Yeah, JL4.
Yeah. So the aortic stenosis, aorta is a little bit dilated, so 3.5 is not enough, and the 4 or 5 is optimal.
코다. 오케이 들었어. 크레니얼.
I think most of
Setting.
the audience have interest in that one, rather than the
right.
TAVI procedure itself.
Yeah. TAVI is boring with the sapien valve. It's always a short calcified lesion, no bifurcation, no CTO. So
You know, the small screening please show us the physiology screening, not your the face or the.
오케이. 피지올로지 바꿔주세요.
Equalization, please.
바꿔주세요. 피지올로지로.
그리고 카메라 FFR 비춰주세요.
그거 겹쳐주세요.
Camera on the screen, please. FFR.
이퀄라이제이션 됐나요?
카메라 몇 번이에요 이게? 카메라 2 on the main screen. Okay.
네, 조금 빼서 우측으로.
And fluoroscopy in the subscreen.
우측.
박 실장님,
우측. 커트만.
엔조를 서브스크린으로 주세요.
오케이.
테스트.
테스트 해야 돼요. 아니요, 할 필요 없어요.
아니야? 오케이. Same.
네, same.
Same position. 오케이.
오케이.
줘야지.
So,
Nicorandil.
resting.
Yeah, we are
Resting
using
FFR is
Nicorandil
0.8.
intracoronary injection. It's published that the intracoronary Nicorandil is quite similar, quite compatible with the intravenous adenosine. So our routine practice is Nicorandil. Okay, we gave it.
See the nip.
Yeah,
7-2.
getting lower.
7-1, 7-2.
Oh,
This is the coronary session. Show
yeah.
us your technique of the stand.
Okay, easily.
This is so fast. Impressive. Yeah.
Okay.
So, do you want to stand LED?
Why not? The
Why
FFR
not?
value
Okay.
is less than
Okay.
0.8.
Okay. Stand it.
Just as long, Gwon, just as long as you're going to do it as boring as the TAVI procedure.
Right.
All right, don't try to make it exciting.
테스트.
No CT required. I
테스트.
guess.
Yeah.
엔진.
It's quite interesting that the afterload is reduced immediately after TAVI procedure. That increases FFR. The flow, coronal flow is increased. So very interesting. Yeah.
One of the message or lesson of this case is coronary stenting before the TAVI, because the
Why
FFR
not
value
during
is
the procedure?
nothing changed.
No, Dr. Gwon, that paper that you quoted, actually, if you look at it carefully, the people who had FFR more than 0.8, it really became much better. But people who
Oh,
had
yeah.
significant reduction in FFR to start off with, they didn't have that much of an improvement in the FFRs.
Oh, really?
Yeah,
Oh,
so they
yeah.
had little bit, but not
Yeah.
not as much significant.
Okay. Yeah, message is that if we have a borderline or a little bit significant FFR before TAVR procedure, you really need the intervention.
비례 찍은
It
거
will
맞아요?
get worse after TAVR procedure. Okay.
Yeah, so this wasn't a borderline lesion
Yeah.
to start off
Yeah.
with.
Yeah. Message taken. Okay.
넥스트. 3mm 되겠죠?
2.5.
2.5.
벌룬.
3mm.
3. 오케이.
3mm 주세요.
3mm 20. 인디플레이터 좀 주세요.
블러드 프레셔를 좀 잘 봐봐봐. BP 제로?
비가 좀 낮아요.
No, but it looks
Zero
like a
Zero
pretty
right?
straightforward
맞네요.
procedure with the coronaries.
Zero
And
again.
if the patient is not having
zero.
renal problems, renal failure, he could put here even a direct 3-0 over 20 millimeter stent and finish it in the
direct.
same
In this
session.
case, actually,
doubt.
I agree.
creatinine is normal.
네, 너무.
Yeah, so. 내가 할까?
I mean, it does have diffuse disease, even the bifurcation, prior to the bifurcation distally, but
좀
the
올려줘.
most important lesion is at the septal, right after the septal.
좀 더. 가이드. 오케이. 테스트.
I think that while he is
Looking
doing
right in.
this, and this is boring, I'm kidding.
Yeah,
Go on,
right.
you're not boring.
I'm boring
But
too.
while he's doing this, I think that a very important point that Gwon has put here, and this is compared to the previous live case of TAVI by Dr. Kim, is that
오케이.
In a case like this, which is not bicuspid and not heavily calcified, he did an oversizing with perfect results. In a case that Dr. Kim had, it was heavily calcified bicuspid. You should always think on a little bit downsizing and the ability to post-dilate with a bigger balloon. So this is very important take-home message for any TAVI in the future, that we're going to see more and more younger and bicuspid patients.
Okay, and you ready? Sure. Okay. 3.5, 4.0? Which one?
3.5.
Previous. Gojan? 28. Yeah, 3.5 is a little bit hard and we need high pressure. Science? Because I use the synergy in the other room. (3.528)
저기 밑에는 안 하실 거죠?
응?
밑에.
No.
28.
3.528. So you can leave us now. I'm very ashamed and I'm very shy and I don't like to show you the PTCA here.
We are curious about the post-stenting FFR.
No.
It'll still be abnormal because there's some distal disease as well. So I don't know whether you're planning to balloon it, if not, or leave it alone.
Maybe you are interested in the FFL after stenting?
No, I'm saying it will still be abnormal, Dr. Gwon, because
Yeah,
there's still distal disease in the LAD.
Distal, yeah. Guiding?
괜찮습니다.
Okay. Usually I don't use Jokin guiding, so guiding is so weak in this case. So, but XB guiding is not proper for this after TAVI stenting. Guiding is very weak. Okay.
Dr.
Test.
Gwon, do you think we can do the direct standing from the beginning? Or do we have to do the pre-dilatation?
Oh, sure. The patient with renal failure, so why not? But in this case, why not pre-ballooning? Because we already find that the lesion is very hard to dilate. So direct stenting, I'm not sure about the 3.5 or 4.0, but in this case, I'm sure 3.5 is the optimal
Dr.
test.
Gwon, I really enjoyed your cases, very interesting, and successful TAVI procedure. And we will move to the Dr. Kim's
Yeah,
lab.
inflation.
Okay?
Say hello.
Okay, thank you.
Okay.
Thank you.
Congratulations. Dr. Kim.
안 된다.